Good afternoon. Thank you all for being here today. I want to be here to personally tell each of you that what I do today, it matters. Everyone in this room knows that our country is in the middle of the opioid crisis, and I'm so proud of the work that this administration has already done to combat this epidemic. We all know there is still much work to be done, which is why you're all here today. I know one panel will focus on the supply side of this crisis, and the other panel will focus on the prevention, treatment, and recovery. Our unified goal is that of helping all who have been affected by drug addiction, and for me, that means focusing on babies and young mothers, which is something I have been often seen in my travels. I want to read some of a letter I received from a woman named Betsy Henderson, a mother who lost her son to drugs. She wrote this letter to me just 1 month after her son passed away. Miss Henderson is here with us today. Betty, please join me. Dear Mrs. Trump, on September 22nd, 2017, a needle took the life of my 29-year-old son, Billy. The day after my son's death, I had to go to the medical examiner's office to claim his body. No mother should ever have to claim their child's body. I'm sure that you, as a mother, would have some understanding of the depths of despair that I experienced on that day. Mrs. Trump, I'm asking for your help in claiming these lost souls before drugs take them from this earth. I pray that we give peace to families in knowing that they told their loved ones how much they are treasured. Patty, thank you for having the strength to reach out in the midst of your grief. Your story touched me, and I know it has now touched everyone in this room. Just as you said in your letter to me, let us all take a moment now and celebrate your son's life. Thank you very much. Thank you. Let's all keep Betty and her son Billy in mind today as you're working through some of the issues related to the opioid epidemic. Sadly, she's not alone in her grief, and we need to change that. Thank you again for your hard work and commitment to this topic. You're all making a real difference, and I look forward to hearing the important action items that everyone will take away from today's summit. Thank you all, God bless you, and God bless the United States of America. Thank you.
Ladies and gentlemen, Ms. Kellyanne Conway.
As you can see, the First Lady joins her husband, the President of the United States, and the entire administration in their commitment to combating the opioid crisis and the drug demand, drug supply epidemic roiling our country. On October 26, 2017, on this very platform, in this very room, the President and the First Lady delivered a joint policy address about this topic. That same day, the Acting Director of the Health and Human Services, Acting Secretary, he declared a public health emergency And the president deployed and directed his entire administration to do their respective parts in helping to bend the curve on the eye-popping numbers and grief and loss that is roiling this nation. Since then, the administration has made great progress, and the purpose of today's summit is so that we can go to the very top of each cabinet and department and agency represented here today and learn what frontline activities are happening, and also to learn the plan and vision for the future from each of those departments and agencies. I really would like to welcome you again to the White House today, each and every one of you. We have a lot of headliners and decision makers among us, but I really want to recognize with great distinction and gratitude for being here those courageous family members who have suffered loss and those individuals who currently are either struggling and or are recovering. We see you, we hear you, and we support you. This president and his administration are focused on law enforcement interdiction, treatment and recovery, education and prevention. I believe now we are going to show you some video footage of a project that is in its nascent stages here at the White House, where we call Opioids the Crisis Next Door, meant to represent indeed that no state has been spared and no demographic group has been untouched. We'd like to, I think, dim the lights and show this, and then we'll start our first panel today. Thank you.
I'm Eric Bowling. I'm a television personality and a best-selling author, and I'm here to talk about the opioid crisis and how it affected my family. My son was a very, very social high schooler, grew up in New Jersey, just outside of New York City. He liked to have fun. He was a normal kid, loved baseball, loved his car. He went to the University of Colorado. He had a fantastic freshman year at the University of Colorado. So my wife and I are out to dinner, having a very, very normal dinner. On the way home, my wife was driving, and my phone rang. It was about 10:30 at night. My phone rang, cell phone, and it was a young man who was panicked. He said, "Mr. Bowling, call Kayla right now." And I said, "What's going on?" He said, "Just call Kayla right now." She answered her phone, and she was crying. I said, "Kayla," for some reason my mind went right to this as a parent. I said, "Kayla, is he alive?" And she said, "No. There's a detective in his apartment." The first week into his sophomore year, Eric Chase died of an opioid overdose. At that moment, my wife, who was in the driver's seat, we had pulled over the side of the road, literally fell into the road. I had to gather her up, and we sat on the curb for about an hour, crying, talking, trying to figure out what just happened. We never saw it coming. We never thought we would get that call. Every parent doesn't want it. We got it. Sorry. So afterwards, your mind tries to figure out what happened, what went wrong. Is it something we did? And then it's also coupled with, what are the people going to think? What are our neighbors going to think? What are our friends going to think? I mean, it sounds shallow, but that really is some of the things that go through your mind. I didn't know where to go. I had no support system. And so I went to Twitter and I said, look, this happened. I was overwhelmed by the amount and number of people who opioids are affecting. What I have done since then is to talk about the stories of people who are worried about a loved one, worried about a child, a brother, a sister, a mother, a coworker, a friend. It helps to talk about it, and it helps to find resources for that help. There's one underlying issue that I think parents need to understand, and is very, very important. I've seen it over the last few months since Eric's passed. Not my kid syndrome. Not my kid syndrome is terrible. Not my kid syndrome is a killer, because you just don't know. It could very well be your kid. So do us all a favor. Do yourself a favor. Do your family a favor. Do your children a favor. Have the discussion with them, and do it again and again, and get involved in your kids' lives. Find out who they're talking to, who they're hanging around with. Keep an eye on what they're spending and where they're spending it. It matters. You can save someone.
The crisis is terrible, heartbreaking. It's probably the worst thing I've seen. I never thought as fire chief that I would be spending so much time on this opiate crisis. But I think in many ways this is kind of a natural thing for the fire departments out there, that because we're a place that you come to for help. January of 2015, we went from maybe 20 overdoses a month to 75 overdoses a month. And that occurred with the influx of synthetic opiates. Last year, we went to 884 overdoses in the city of Manchester. That doesn't include the overdoses for methamphetamines. Those are just opiates. In May of 2016, we started a program called Safe Stations. The first day I was promoted to chief, I opened up all my fire stations to anybody seeking treatment or seeking help for substance abuse disorder. If it's at 2 o'clock in the morning, if it's during the day, we're always there. We're in all the neighborhoods, and we welcome people in. We treat these, people who are addicted with just very non-judgmental. We'll help you. We'll get you into treatment. If you want treatment, we'll give you a shot at treatment 100% of the time. No one agency can do this themselves. My Safe Station program in the city of Manchester is just a small piece of this. We've seen a 30% reduction in our overdose death rate last year alone. So we went from 90 overdoses to about 64 overdoses. So we know we're saving lives. We're saving lives every single day we go out there.
I'm a physician. I have a master's degree in public health. I'm the United States Surgeon General, and my family is suffering from substance use disorder. My brother Philip is in prison due to crimes he committed to support his addiction. His illness has affected my entire family, emotionally, medically, and financially. As a trauma anesthesiologist, I've seen things that would make the average person cringe, but nothing has shaken me quite like seeing the barbed wire and the thick metal bars when I first visited my little brother in state prison. It was all the more agonizing because despite my knowledge and my experience, I couldn't prevent or fix his illness. I'm hopeful that by sharing my story, it will help people understand that addiction touches every community and that they are not alone. That's why I'm asking everyone to partner with me in this fight for a healthier country. Because for me, and for all too many Americans, stopping the opioid epidemic is not only pressing, it's personal. I encourage you to share your story along with mine so that we can break the stigma.
I've seen one or two. Ladies and gentlemen, our first panel is on prevention, treatment, and recovery. It's my great pleasure and privilege to welcome to the stage Secretary Azar, Secretary Carson, Secretary Shulkin. Secretary Azar, if you would begin with your opening comments. Thank you.
Kellyanne, great. Thanks to the First Lady for those important and personal remarks to kick this off. And Kellyanne, thank you for that wonderful video with those personal stories. I think it's so important to have that message out there of not my kid, because this can impact and hit just anybody. I want to thank President Trump also for making the opioid crisis such a priority. I can assure you that in my discussions with him, it's a constant point of focus for him of ensuring that we're taking bold enough action and devoting enough resources to the challenges ahead. It's a pleasure to be joined here by Secretary Shulkin and Secretary Carson also, as we really work together as an administration to tackle this crisis. I want to start off with an important statement. At HHS and across this administration, we know that we need to treat addiction as a medical challenge, not as a moral failing. That informs HHS's work across all three areas that we're here to talk about today: prevention, treatment, and recovery. And it's why the President has directed HHS to consider the declaration of the public health emergency last fall, and why we declared such an emergency on October 26, 2017. This emergency declaration has brought a new level of focus and coordination and cooperation to our work across the federal government as an entirety, and so I want to give you just some examples of what has happened and what we've accomplished since then. First, we know it's essential to prevent people from getting addicted to opioids in the first place. We've seen promising news on appropriate opioid prescribing. Prescribing is down noticeably from 2010 to 2015, but it's still 3 times what it was in 1999. Just one example of our work on this front. In December, as part of a broader reform initiative to use data better across HHS, we held an opioids codathon. I had to learn that word, codathon, where we brought in top data scientists from schools like Yale, Stanford, and Hopkins, and top tech companies. And what they did is the programmers spent the day coming up with new tools for prevention, like apps that use existing data sets to monitor risky opioid prescribing and help providers assess their own prescribing levels to see if they were out of the norm and needed focus on their own habits. We also know treatment, including evidence-based methods like medication-assisted treatment, is essential to this fight. Shortly after the public health emergency declaration, we announced a streamlined process for states to get waivers that could support substance abuse treatment, and we've approved 5 of these waivers so far. This weekend at the National Governors Association, I actually berated the governors saying, why have I only gotten 5 of these so far? I told them we're eager to work with them. We have a streamlined process for considering them, and I want more. At the NGA, we also highlighted 2 forthcoming Food and Drug Administration guidances that will expand and accelerate medication-assisted treatment. One of them will help the development of long-acting depot formulations like the monthly shot that was approved this past fall, and one that will open up new ways of assessing medically assisted treatment effectiveness by looking at metrics besides just achieving abstinence, complete abstinence, so alternative endpoints. On recovery, this year and last, we're issuing $500 million per year in targeted response grants to state governments, which cover prevention and treatment, but also recovery supports. These supports are a key piece of successful treatment, including medically assisted treatment. To support that grant program, we announced a new method of technical assistance in November to use more local experts and expertise to provide technical assistance to states and grantees rather than a traditional one-size-fits-all approach from Washington. The goal is also to emphasize truly effective evidence-based policies. The President's budget also proposes doubling these state grants to $1 billion a year as part of a historic $13 billion package in proposed funding for this crisis. That's just a small sample of the work that we're doing, and all of it requires the contributions and cooperation of our partners on the front lines, which includes many of you here in this room. That's why the President's holding this event today, so we can share our work with you, and so we can solicit your input on what we need to do further. So thank you for joining us here today. And we and all of our partners across the federal government look forward to working with you as we tackle the scourge of this opioid crisis. Thank you.
Secretary Carson, thank you. Secretary Azar, thank you so much for those remarks.
Well, first of all, thank you, Kellyanne, for leading out in this endeavor. I'm grateful for the leadership of the President and the First Lady and my fellow cabinet secretaries as well as the Surgeon General for bringing this to the level of attention that it should have. It is affecting virtually every part of our society and the very fabric of our society. And I'm also grateful to all of you who've come here to show your interest and support for what's going on. Everybody has a sphere of influence. And together, we can really take this important issue to where it needs to be. At the Department of Housing and Urban Development, the human cost of opioids is all too familiar to all of us. For us, drug addiction lands at an intersection of health, housing, and economic opportunity. It is especially dangerous to the communities that HUD serves. So we're being especially vigilant in our efforts to address this epidemic and all of its consequences. In fiscal year 2017, 76,000, or approximately 25% of those served at HUD-funded continuum of care, reported substance abuse issues. That's a lot of folks. Moving forward, we have convened senior leadership from all program offices, working collaboratively to recommend near-term actions to impact both awareness and treatment. We've also convened all program offices to think through the strategic changes to rules and guidance that will support the efforts of law enforcement to tackle drug traffickers and drug use prevention and treatment for those struggling with addiction. We are continuing to study local success stories across the country, identifying good models and data to be integrated into HUD's notices of funding availability that have proven to be effective and are promising in addressing substance abuse. And that is really a key factor when it comes to making progress. When you look at the turn of the century before this past one, the average age of death in America was under 50. And at the most recent turn of the century, we're approaching 80. How did that happen? It was because the medical profession began to make its policies and its recommendations based on evidence. And it makes all the difference in the world. These conversations with public officials, private foundations from San Diego to New York are ongoing. Our new Envision Center initiative will have community health and wellness as one of its core missions. The Envision Centers will work to improve access to health services, including drug treatment and prevention for those struggling with drug addiction, including opioids. But it is important to note that the scourge of opioids in America is not simply a crisis of health, it's also a crisis of hope. The Envision Centers will also leverage public-private partnerships to promote long-term economic, educational, and employment opportunities in our communities, all things which bring hope. Once more, Americans will have the tools to build a brighter future, and fewer of them will try to escape their current realities through drugs. This is a challenge that will take our combined resources and ingenuity to solve. But together, we can solve it and save thousands of lives in the process. I look forward to further collaborations with my fellow agency heads and all of you in the coming year.
Secretary and Dr. Carson, thank you. Secretary and Dr. Shulkin, you're on.
Thank you very much. You know, as I look around the audience, there's just such amazing expertise and personal experience with this issue, and whenever I go to an event, I always have a goal of taking away a message or meeting somebody that's going to help me. So thank you all so much for being here, and I hope that you too will meet people in this room, learn something, and take away something to help contribute. I really want to also thank the President and the First Lady for giving us all this opportunity to be here. And I have 3 points I wanted to share with you in the hope that you'll take something away as well. The first is that I do believe, I'm optimistic, that we can make a difference, that we can really help save lives. At the Department of Veteran Affairs, as you know, we're the largest health system in the country. We began to see this problem in opioid addiction and crisis before maybe other health systems. We started focusing on this in 2011, and in 2012 we launched the Opioid Safety Initiative that has put in over $300 million into prevention and treatment. Since 2012, we've reduced the number of opioids used in the VA by 41%. And the way, if you take a look at that figure of a 41% reduction, it's come through a 90% reduction in the start of new opioids. So by looking at alternatives, instead of just reaching for the prescription pad, as probably Dr. Carson and I learned when we were in medical school, we've had a 90% reduction. So there is hope out there, and we can do better and save lives. Second point is that as we begin to share best practices, we have a lot to learn from each other. Kellyanne, and thanks to her leadership, and Governor Christie, who helped lead our commission that I had a chance to participate in, we went around the country and visited places that were really doing this well. The Department of Veteran Affairs took an unusual step about 2 months ago, and we now publish publicly all of our opioid prescribing rates for every VA medical center across the country. Now, we're the only health system in the country that does this. There is nobody else doing it, but we did it to try to encourage others to follow the lead. If you take a look at data.va.gov, you'll see all of our prescribing rates. You'll see the highest in the country is in Roseburg, Oregon, at 20% of all prescriptions, to the lowest in the country in Cleveland at 3%, where Kellyanne and I went to visit. So by sharing these practices, we know that we can help each other learn, and I encourage the rest of the country to help participate, and the VA is there to help teach. The third and final point, I just wanted to share the way that we've gotten this 41% reduction and this 90% reduction in new opioids. At VA, I quickly learned if you have something important, you better develop an acronym, because there is no initiative at VA that doesn't have an acronym. So I actually made this one up. It's called Stop Pain, okay? So the S in Stop Pain is for a stepped care model. Instead of reaching for opioids initially, we have a stepped approach towards pain management where opioids is at the end, not at the beginning. The T is for treatment alternatives, and we've really focused on integrative medicine and non-medicinal aspects, as well as Secretary Azar talked about, the medication-approved treatments that offer alternatives when people are addicted. The O in STOP, the O is for ongoing monitoring and usage. So we actually use data to identify where there are problems, where there are bumps in high usage rates, so that we can go and effectively intervene. The P is for practice guidelines. I'm proud that the Department of Defense, the Department of Veteran Affairs, the CDC have all jointly published pain management practice guidelines available in the public domain that we teach our clinicians. The P for pain is for prescription monitoring. We participate in the state data prescription monitoring programs, which are really important in the state, so that we as doctors, I'm still a practicing internist, I go to these state practitioner databases to see if other doctors have prescribed medication. The A for pain, the A is for academic detailing. We send our pharmacists out to train our doctors into how to appropriately prescribe opioids. The I is for informed consent. We have our patients sign informed consents before they use opioids, because they have a shared responsibility in this. And the N is for naloxone distribution. At the Department of Veteran Affairs, we've distributed over 100,000 naloxone kits to our first responders and to veterans themselves, and we know that that saves lives. So I hope maybe you'll pick up one of those and continue to share your experience, and together I know we can make a difference. Thank you very much.
Thank you very much, Secretary Shulkin. Now we'll take some questions from the audience. The first question comes from Carla Strunk from Richmond, Kentucky. Hi, Carla.
As you said, my name is Carla Strunk. I am from Richmond, Kentucky, and I would like to just say that I'm here because I lost my only son to the opioid epidemic. I would like to share this as his picture. And I did that because I made a promise to him that when I lost him, that I would fight. So I'm here today not only for myself, but for everyone that's lost their child or their loved one to the epidemic. My question for the panel is that since this has happened with my son, I've had the opportunity to go out in my community, be part of the U.S. Attorney's HEAT program, and go into the schools, because my son's addiction, like most, started at a very young age. So my question is there a plan to put something like a prevention program into the schools nationwide? I've seen the effect that being able to go in and talk to these young kids who don't understand that your first time using probably could be your last time. It's very effective. Thank you.
What, first of all, what was your son's name? Brendan. Well, I mean, thank you for sharing that story. Does anybody have any particular thoughts about schools? Okay.
Thank you very much for being here, Carla, and I'm with everyone in telling you how sorry we are for your loss and how moved we are by your courage to channel your grief into something positive for other families and other students. The First Lady and the President and Secretary DeVos and other stakeholders and decision makers are very invested in making sure that we communicate a message of prevention and education, particularly to our youth, and that the First Lady is very committed to the well-being of children overall, and this would be a part of that. We, I think, to begin just by educating each other, not just on the harrowing statistics, but on the basics. I would imagine most of America suffers from information underload when it comes to fentanyl, for example, which took the lives of 20,000 Americans last year. And if 20,000 Americans were dying every single year from almost anything, we would stop and turn our attention to that immediately. So I think what the President and others are urging is let's stop and at least turn part of our attention to that. So getting into the schools, making this part of the curriculum is a goal. I've had occasion with my colleagues inside the White House and across the administration to learn all the great work that's being done in the private sector and the nonprofit community. And I'd invite others to come forward and tell us what they're working on so we can see their best practices. But there are a lot of folks out there who have developed great ways of communicating with youth. And it's not just youth. If we can tell people the way the President told them on October 26th that the last Saturday of every October and every April we have the DEA runs what's called Take Back Day. Why not make Take Back Day every day somehow? If we can work with the pharmacies, if we can work with the local first responders, to the extent that it doesn't overtax them, but to the extent that we can tell people you don't have to wait for twice a year. There's a way to safely dispose this. Some of the private sector businesses are working on this as well. But we have to get to youth, whether it's after school, community messaging, and that is a big part. This is why the President is committed to education and prevention. He's also committed to interdiction and law enforcement, of course, treatment and recovery. I would also note that the President's Commission on combating the opioid crisis and drug demand had 56 recommendations that they issued. The Commission did great work. The President has accepted all 56 of those recommendations. It's a public document, and this is covered there as well. Our next question comes from Ryan Hampton from Pasadena, California. Ryan? Hi, Ryan. There's a mic coming.
My name is Ryan Hampton. I'm a person in sustained recovery from a substance use disorder, and what that means to me is that I haven't felt it necessary to have a drink or a drug, and most importantly to me, heroin or opioids, since February 2nd, 2015. Thank you. And I know how incredibly lucky I am to have made it out of this crisis alive, but I also know that recovery and access to recovery and recovery supports should never be about luck. And in 2015, when I got out of treatment for the last time, I was able to access stable recovery housing and recovery supports that came with that. And I know that if it weren't for those 18 months of that stable housing, I probably wouldn't be here today. Also, in the last 2 years, I've probably lost way over a dozen friends, people that I care about, people that I love, people in my community, to accidental opioid overdoses. The majority of them were not able to access the full continuum of care that included stable recovery housing. So my question to the panel, the whole panel, would be, since we know that the first 5 years of someone's recovery is most important, how can we support people through that full continuum, specifically when it comes to stable, qualified, and ethical recovery housing and residences? Thank you.
Well, thank you for that question. As I mentioned in my opening, there is a true nexus between opioid abuse, drug abuse, and housing. And That's why it's so incredibly important, and that's why one of the reasons that Housing and Urban Development has coupled with the VA for the HUD-VASH program and various ways of making sure that our veterans actually have a secure place from which to recover. But it spreads, far beyond that. It's all aspects of our society. And we have continuum of care programs. We've devoted a significant amount of money to that very issue of providing the kind of recovery that's necessary. I think it's critical that people understand that people who are addicted to opioids are not like them, and then there's us. I mean, it's all of us. It can be any of us at any time. It is so easy to get addicted. And has nothing to do with socioeconomic class or anything else. And we need to recognize that in our society right now, it permeates to the extent that probably anybody that you talk to knows somebody or has a family member who has been affected. If you talk to manufacturers, they will tell you that it is very difficult to find people to work who can pass a drug screening. So that gives you some idea of the pervasiveness of this in our society. And that's the reason that we have an interagency cooperation working with HHS, all of us, recognizing what an incredible scourge on our society this is and how it impacts virtually every portion of us. But as you have very correctly stated, we do understand that providing the kind of place where they feel secure and stable is the first step. And when you're talking about recovering from opioids, you're not talking about a few weeks. You're generally talking about 18 months. So it's a long-term commitment. And as a society, we have to recognize that until it becomes as easy to get treatment as it is to get the drugs, we're not going to win the battle.
And the issue you raised, Ryan, about that kind of support in the recovery period, that's why the President's doubled the amount of state treatment and response funding grant programs from $500 million to $1 billion. We already put out more money to states and localities last year than ever before in history, and now that's gonna more than double, doubling in just that type of grant to $1 billion that can be used to help with these kinds of programs. And then we're putting out $75 million of naloxone funding so that the first responders can have access to adequate supplies of naloxone at a good cost. We're also working to create a $150 million grant program for rural treatment, so that not just in Pasadena, but also in more remote and rural parts of our country where folks really are in underserved areas from a treatment perspective, that we can provide more support there. Another almost $500 million for community health centers, which provide such a vital safety net for folks for treatment, response, and ongoing recovery. So it is, I'd say, even beyond the 18 months, as I mentioned in my opening, I think of it as a lifelong process for folks.
Thank you very much, and thank you, Ryan. The First Lady of North Dakota is Catherine Burgum. She's been an inspiration to many people who have heard her story, and today she'd like to talk to us about destigmatization and something the President has talked about, breaking through the silence and the stigma. Catherine?
Thanks, Kellyanne. I am so grateful to the administration for bringing together these stakeholders and decision makers for this important conversation about ending the opioid crisis. I've been in long-term recovery for 16 years. Thank you. And I know from personal experience how stigma prevents people from reaching out for help and talking about the disease of addiction. I did not seek real help for almost 20 years because I was ashamed. Stigma puts up walls. It is socially constructed, based in fear, and usually contains inaccurate information. If we can begin to normalize the conversation around the chronic brain disease of addiction and talk about it like we talk about other chronic diseases like diabetes and heart disease. We can end the stigma. We can change cultures from misinterpretation to empathy, cultures in our communities. It's so great the administration has created this website for people to share their addiction and recovery stories, because that's going to go a long way to breaking down the barrier of stigma. In North Dakota, we've launched a multi-year, multimedia communications campaign designed to inform about the disease of addiction and eliminate stigma. We call the campaign our Dream Again campaign. So my question is, has the administration considered a communications campaign that promotes understanding and empathy towards those struggling with the disease of addiction? And just know I stand ready to help this administration in any way I can to eliminate the opioid crisis and the stigma of addiction. Thank you.
So we do anticipate launching a mass and multimedia campaign, not just to educate people about the dangers of addiction, the fact that just the risk, the fact that it can come to anybody, to any family. And as part of that, I do think the destigmatization of substance use disorder is critical. We have to get people willing to seek out treatment. You know, it's one of the reasons part of our program is to support drug courts also, to just allow diversion for people so that it's not about just going, you know, just facing criminal consequences, but can we get people into appropriate substance use treatment programs, which is the help that they often really need. And so our multimedia campaign, I think I'm glad to get this feedback from you about destigmatization so that as Kellyanne and I and others work on this, we can ensure that those messages are part of the campaign also. Thank you.
The education is absolutely critical, and it's one of the components of the Envision Centers that will be populating places throughout the country. Comes from a Bible verse that says, without a vision the people perish, but we call them Envision Centers because we didn't want people to think they were going to get glasses. But, but there's a strong educational component. And prevention is a key portion of that educational component also. So coupling with many of the nonprofits and philanthropic organizations that are already in our various communities, bringing them together with the need, putting them in juxtaposition, I think will have a very good impact.
Thank you. Gary Tennis from Harrisburg, Pennsylvania. Gary, welcome.
Thank you so much, and thank you for pulling all of this together. I am president of the National Alliance for Model State Drug Laws. Before that, was secretary for the Pennsylvania Department of Drug and Alcohol Programs, and most of my career was a prosecutor in the Philadelphia District Attorney's Office for 26 years. During those 26 years, I saw a parade of individuals, of criminal defendants going before me with untreated or undertreated addiction. Most of the problems we were trying to solve in the criminal justice system were a consequence of a failed healthcare policy of not providing enough treatment. As you all have said, the resources have never been there. I would say probably this is a multi-pronged problem. There are many aspects to the solution. I've been looking at this problem now for 30 years. The biggest single blow that this administration could deal in terms of ensuring more people get treatment is to make clear that the IMD exclusion, which was meant to stop the warehousing of the mentally ill, is no longer applied in the area of drug and alcohol addiction treatment. It never was meant for that. There was never a problem with warehousing the mentally ill or warehousing people with drug and alcohol. So I would just ask you, I know you're looking at the waiver process, which is time-consuming. It has various idiosyncrasies. Would the president or the administration consider just dealing with a single strong, powerful blow by saying the IMD was for mental illness, it does not apply to drug and alcohol addiction treatment?
So Gary, we agree about the IMD exclusion. This is a provision that, as Gary mentioned, was intended decades ago. well-meaning to prevent the warehousing of people with mental illness into these giant state institutions, sort of the stereotypical thing. And it was a provision that said that Medicaid funds cannot be used for facilities that have more than 15 beds. And so what President Trump did is actually create this streamlined waiver process so that states can come in and for substance use disorder, exactly the issues Gary talked about, grant that permission so that we can indeed, at the state and federal level, reimburse for inpatient treatment for substance use disorder. It is a very streamlined process. In fact, this was the issue that I was raising with the governors this weekend, is oftentimes governors will come in with a whole package of requests around their Medicaid program to do a whole restructuring of Medicaid that presents unbelievably complex financial and statutory and legal issues. And I told them, just separate your waiver requests for the IMD exclusion, and we'll handle those as a separate, streamlined, fast thing. Let's not let them be slowed down by the broader reforms you're trying to do in your Medicaid program. And so, in fact, we did that right here in the Red Room with the governors. And so I'm hopeful that we will see a faster clip. We can handle those quite quickly. Those waivers are very easy to do. It is a statute, and the president's budget has proposed changing the statute. As long as the statute is there, however, I've got to use my waiver authority, but we're open for business on them. I made that very clear to all the governors, and we will process them very quickly.
And Gary, let me just say thank you for sharing your experience. In the Department of Veteran Affairs, I'm sure you're aware, we have veteran courts throughout the country, and they're set up to do exactly what you're talking about, to allow judges to understand that rather than sending people to prison for substance abuse and other mental health issues, get them right into treatment. We do this around the country with thousands of veterans, and we have an 80% reduction in one-year recidivism back to prisons. We're getting people that help. So I think it's exactly your experience, and I know Secretary Azar, through the waiver process and the statute change, is going to allow us to do that for more Americans. So thank you.
Cece Brown, a woman I've come to know and who we rely upon for... Cece, you're here? There you are. Cece, thank you for being here today if you have a question.
Yes, I do. First, I want to tell you the reason I'm here. It's because we lost our son, Ryan, to a heroin overdose. He died in a very public place. He died of a heroin overdose in Macy's bathroom. And at that time, when the detectives came to tell us what had happened, we said we didn't want this to happen to one more person. And that's exactly why we're here. And these two individuals that have had the courage to speak up, that gives me hope, and I hope it does you as well. I'm so grateful for you, what you're doing, the focus on the opiate epidemic. But Ryan was on a wait list for 2 programs when he died. And what he said to me, I was walking down the hall, and I saw him sitting in his bedroom, and he looked at me and he said, "Mom, I'm trying. I'm trying." And of course, he met someone at the mall unexpectedly, and there it happened. He hadn't been using. But that's my concern. We started Ryan's Hope, an organization to raise awareness about addiction and overdose, and also to advocate for recovery. The reason we named it that is I said to Ryan, another day is a day of hope. And if people don't have opportunity is everything. And that's what this whole thing is about for me. It's about people, and it's about saving lives so we don't have any other parents to go through this, so we don't lose another son or a daughter. I get a little passionate. But I think it's so important. So this leads me to my question. Of the $6 billion that is budgeted for the opiate epidemic, can you tell me what is targeted for prevention and treatment? Reason being is that I think we need to get ahead of it. We sent Ryan to college, and that's where it all started. I went to a training session on how to talk to kids about drugs, and guess what? I sat there and just checked each one off. I'd done it. So something was not right. Something was not. So I do think we need to look at things differently with prevention and put a face on it. You know, in the schools or wherever, whether it's in church, actually help with the sound system at church. And had a scholarship. So that's what I wanted to know is what's going to be dedicated to treatment and prevention, because that's just critical for me. Thank you.
Thank you, Mrs. and Mr. Brown.
Well, that's that's a very important question. I can't give you percentages, but I can tell you a few weeks ago I was in Kentucky, and they have hope centers there for the purpose of treating people who've been addicted. And these are all public-private partnerships. So of the $6 billion through the various agencies, a lot of it is going to be used in conjunction with state and local programs. And that's where the real impetus comes. It's not necessarily from a federal bureaucrat, but it's from the people in the neighborhoods who are right there with boots on the ground. And there's so much compassion in our country. And there's so much philanthropy in our country. So what the government actually provides in these private-public partnerships is probably the minority of funding and the minority of attention. It's going to really come locally, and it's something that really needs to be encouraged.
And Cece, I would say within how the Department of Health and Human Services will spend its portion of the money, essentially all of it is prevention, treatment, response. Some of it longer-term treatment. So for instance, in 2019, we would be dedicating over $750 million of our funding to the National Institutes of Health to develop the next generation non-opioid pain treatments so that we can hopefully stop people from even beginning and getting into the system through legal opioid use for pain, through alternative therapies that are non-opioid for pain treatment, in addition to studying alternative therapies to deal with pain beyond the pill. And so that's something else that NIH is funding. So I'd say longer-term prevention there, the rest much more what you would think of as traditional prevention, treatment, response recovery programs. I spoke this weekend how 1/3 of our treatment facilities in America have medically assisted therapy. That's unacceptable. It's a proven evidence-based approach. There are many approaches to addiction and treatment. We know this one works though, and 1/3 is not enough, and we need to use this funding we're getting to build up more medically assisted treatment facilities.
Thank you very much. We have 2 more questions. Dr. John Rosa of Darnestown, Maryland.
Are we on? There we go. Thank you. First, I want to thank the President, First Lady, administration, panel, participants. We have a lot of experts and families that have been affected, so thank you very much for being able to put something like this together. My name is Dr. John Rosa. I have 14 integrative medicine clinics in the DMV, which incorporate medicine, chiropractic, physical therapy, acupuncture, yoga therapy, mindfulness, nutrition, supplement treatment for pain. Many of the government agencies and some organizations like the CDC, FDA, the VA, American College of Physicians, Joint Commissions have suggested and/or required physicians to use these alternative treatments as the first line of care in lieu of medication. 90% of the consumption of opioids comes from this country, and we're 5% of the world's population. So the other parts of the world have obviously been using these type of alternative therapies to combat pain before that prescription's written. And that's just to let it sink in. Over 90% of the opioids produced are consumed by the United States of America. And I also treat professional athletes. So if we get an NBA player who gets hurts his back, we have 4 or 5 experts on this guy immediately. There's a chiropractor, there's a therapist, there's an orthopedic surgeon, there's the trainer. He's treated 3 times a day until he's okay to practice. When he practices, we videotape what he's doing so we know that his motion's okay. He gets to be cleared to play ball when he is in pre-injury status. Same guy gets hurt, same exact condition, goes to the medical office, gets an opioid, gets sent home for rest. Where does the breakdown occur? We know that these research methods of treating people and that are scientifically proven and used in professional sports not good enough for the average person. We're creating a society of chronic pain patients because when they go home with that first script and they're not treated right away, the propensity for this to be a reoccurring condition in the future goes higher every time that episode occurs. So going way upstream in prevention is to stop that script from ever getting written. We've touched on it a bit, but part of one of my clinics out of the 14 is a free clinic in Maryland. And in that free clinic, it's in a very busy medical practice, primary care, and within a year's time, we've reduced the script writing by 70% for opioids in that clinic. Now, I went and we had our meeting, and I said, you got to tell me what happened. 70%, 10% you write a paper, 70% you call somebody. Yeah, and the answer was, well, you're here. Can it be that easy that if it's available, you're not going to have that process take place? So my question, with all that emotion, because I obviously head into this, but the question would be, how do we instill the proper referral for and the insurance reimbursement of these known evidence-based alternatives for treatment? And I am at your disposal at any time because I've been doing it for so long, so feel free to call on me when needed.
Well, Doctor, that's exactly the issue I was mentioning to Cece a second ago, which is the investment that we're making at the National Institutes of Health around alternative pain management to build the evidence base to support reimbursement. We also, it's a fair point, we need to look at our reimbursement systems, which were really built in the 1960s around siloed ways of paying for a drug, paying for a device, paying for a procedure, and set in statute in a very concrete way that isn't always as adapted and adaptable to evolutions in non-traditional forms of treatment. So in fairness, we need to look at that, and we need to do so from an evidence base, working with our National Institute of Health and the Food and Drug Administration. So we've got that charge, and that is part of our focus.
Yeah, I think about what you're trying to do with 4 different approaches, and Secretary Azar just mentioned 2 of them. You have to have the providers in your network, if you have an insurance plan that has access to them. You have to be able to pay the providers for those types of alternative or integrative therapies. But there's 2 other things that we've learned in the Department of Veteran Affairs. One is we encourage team-based approaches to care, and I think that's what you're doing in your clinics. Instead of it being a solo provider, we have teams of nurses, doctors, physical therapists, pharmacists, social workers, all of whom then can suggest alternative approaches. And finally, what we're doubling down on in the Department of Veteran Affairs now is teaching the patient, in our case the veteran, self-care, and letting them know how do they take care of themselves and what alternatives should they be thinking about rather than just listening to what a provider says to them so that they're an active participant. So I think when you take those 4 things, we can see more of what you've been able to experience.
Our last question is from Greg Delaney of Ohio. Hi, Greg.
It is such an honor to be here with you folks. Much like my sister and my brother here, I'm in long-term recovery myself, 10 years in July, so it's wonderful to be with others. I nearly lost my life to addiction, and yet while I was coming through recovery, it was the work of a pastor that really made all the difference for me. And so what I wanted to kind of talk about is that since that time of intervention from him, we've had the wonderful opportunity in Ohio to try to mobilize our church and faith community to being a part of the solution in this particular crisis. And we've had wonderful relationships with our Attorney General, Mike DeWine. We've expanded those in with Attorney General Morrissey in West Virginia. Probably done 60, 65 forums with faith leaders, trying to help them find their lane. Many of them have found their lane, but what they have found is that to navigate funding for their lane has been intensely difficult because of their faith-based nature. So my question on behalf of all of them today, and myself as a pastor, who have buried about 12 folks in this challenge, how can we eliminate some of the perceived or real barriers to some of this funding for those that are doing great grassroots work at the faith-based level? Thank you.
Well, glad you brought that up. You know, the faith-based community is one of the real foundations of American values, and have taken on the responsibility of helping those, particularly those who are helpless, or who, as the book of James says, the fatherless and the widows, the people who need our help the most. That certainly includes those who are addicted, which affects their behavior, which frequently puts them in a very vulnerable position. At HUD, we have grown our faith-based component, and I think that's been the case in several other agencies. The President and the White House has made a very significant effort to make sure that we protect the faith-based community and religious freedom, while at the same time respecting everybody's beliefs. That's really the key. So I think you will find this effort that we're putting forth will very nicely encompass the faith-based community.
And please grab me afterwards. We each have faith-based offices. Our job is to remove barriers to faith-based providers of services who may be unfairly discriminated against in the provision of critical care to our people. So at HHS, I'd like to know if we're getting in the way of that, or there are things that we can do to be better. So thank you.
Thank you. Please join me in thanking Secretary Azar, Secretary Carson, Secretary Shulkin. Thank you very much. Thank you so much. Thank you. Ladies and gentlemen, I'd like to call to the stage Jim Carroll. He's the Acting Director of ONDCP, and he'd like to make a few remarks.
Thank you. Thank you, Kellyanne. It's an honor to be here today, and I greatly appreciate the trust the President has placed in me to work with you all on this issue. Since I just started about a week ago, I have not had the opportunity to meet with many of you quite yet, but I'm looking forward to doing that in the coming months and years. This is one of the President's greatest priorities, and it is an honor to be here with you today. In addition to the many families that are here, I also want to recognize that we have about 12 police chiefs from across the country who came to hear this message and to share their stories with us. Like so many of us, law enforcement families are not immune from this epidemic. I wanted to tell you a little bit about myself. Like Dr. Collins, I started my career as a state prosecutor, where I spent the vast majority of my time prosecuting drug cases. But I just didn't spend my time inside a courtroom. I also was out there on the streets with my colleagues, the law enforcement officers out there, to actually understand what they were going through. So I've seen how this tears families apart. I went on to the private sector at a large corporation, was the global director of compliance. And so I became involved and aware of the importance of a strong employee assistance program to help our employees through this, because this becomes an economic issue as well. Here at the White House, as Deputy Chief of Staff, I got the opportunity to work behind the scenes with Kellyanne as the leader in this effort, and work with many of my colleagues here on the stage today. Since I started last week, I did have the opportunity to meet with Tony Luke, who runs a chain of cheesesteak restaurants in Philly. Congratulations to the Eagles this year. Tragically, as many of you know, he lost his son as well last year. Yesterday, I met with this beautiful, kind-hearted woman who's raising her granddaughter as her own daughter fights this challenge. So many families have been affected by this. When I met with the First Lady of North Dakota, who is here and shared her story with me, she mentioned that in North Dakota, I think it's 1 out of 7 either has a family member, a friend, or a neighbor who's been impacted by this. For the first time publicly, I want to tell you that I am that 1 in 7, that I have a family member who has been touched by this. And last year I was in the rehab center with my family member, holding that person's hand, helping them through this, and trying to be that support system. And so it's a great honor for me to take this on. This is a professional and a personal challenge for me, for the President, and every member of this administration. The last thing that I want to close with is that sadly, at the Office of National Drug Control Policy, we have a collection of prayer cards from the funerals of so many young people. Pastor, you talked about that, how many funerals you've been to. And so we have a collection of the prayer cards. And one I keep on my desk is for a young man named Archie. And it reads, "God of love, graciously ease our burdens from this epidemic. Calm our anxieties and strengthen our faith." I look forward to working with you all on this great epidemic. Thank you, Kellyanne. Thank you, everyone.